Welcome, everybody. It's Dr. Linda of the Vascular Birthmarks Foundation. Happy Saturday. Today we are live with Dr. Ann Comi of the Kennedy Krieger Institute, Johns Hopkins. And we are experimenting. This is our first integration of Zoom with Facebook Live. So we need to know if you can see us. Send us the little hearts and things that say you can see us. And anyways, welcome, Dr. Comi.
Great to be here.
Thank you for being here. I'm going to pull it up on my phone so that I can see the questions and see how this is going to work. I see us. There we are. Okay, so you are live. Corinne is saying hello from Seattle. I hope you guys will have a geneticist too. Yes, we will do that, Lori. We are going to have a geneticist now that we can integrate all this. So we have people coming on. I can't see on the screen, Emily, any of the questions. I can only see us. So how will I see the questions when they answer?
You can view your phone.
Yeah.
We'll come that way.
Okay, so
I'm right here too.
I don't know. I'll have to read them then for Dr. Comi. Normally they're scrolling on the screen, everybody. So like I said, this is an experiment. We hope you are all staying safe and well during this once in a century pandemic. Hope you're all staying well. And Dr. Comi is actually available right this minute. I'm looking on my phone to see your questions. So I see Tam Bam, Laurel is on, and 4 others. Nikki, hi Nikki Andrews. Greta, hi Greta. Corinne, can see both you perfectly, great. Not more info is in literature. Yes, so Laurel's talking about genetics, but you can actually address why I'm looking at these questions, the GNAQ gene and your study with Sturge-Weber. So why don't you talk about that for a few minutes or a minute?
Certainly. So back in 2013, working with Dr. Jonathan Pesner and other colleagues, we published the finding of a mutation, the R183Q mutation in a gene called GNAQ, causing port-wine birthmarks and Sturge-Weber syndrome. And this told us a few really important things. First of all, that the mutation, the change in the gene that causes Sturge-Weber syndrome port-wine birthmarks is somatic. That means that it happens after the fetus begins to develop in the mother's womb, and it's not inherited. So that's really important for families to know. In over 20 years of doing this, I've never seen 2 siblings with Sturge-Weber syndrome, and I've not seen a parent and a child with Sturge-Weber syndrome. So it's not inherited. So that's really important. And then the other really important piece to know is that I can't make the diagnosis of, so if a baby comes with a port-wine birthmark on the face, a high-risk birthmark, I can't tell them whether the child is going to have eye or brain involvement based on testing for the gene. It's the same mutation, whether they just have the birthmark or they have the eye involvement and the brain involvement. If one wanted to test for the gene, you'd have to do it from a skin biopsy. You can't do it from the blood. You have to do it in the skin because that's where the mutation is present. It's present in the affected tissue, not in the blood. But it doesn't help us determine whether the eye or the brain is involved. There are a few times where we do get genetic testing, and those are times where the child has features overlapping with other genetic mutations. So for example, if the child has a large head and a large forehead, and we're wondering about capillary malformation macrocephaly syndrome, whether the child has that or maybe Sturge-Weber syndrome, then we might get a skin biopsy to test and see if the R183Q mutation is present or a PIK3CA mutation might be present.
Very, very interesting. Laurel's posting and just saying she has a very small birthmark on her wrist, but had the RAS1 mutation. And then they found she had, and I think I had talked to her about this, to look into the brain AVM. And sure enough, she had the brain AVM, which made me, I've been having these discussions with Dr. Coletti about do that. Maybe we need to start looking at the CMAVMs to see if they all have an undiagnosed brain AVM, and maybe it's acquiescent, but we're just seeing so many. And then we had a daughter and a father combo, and the father had a birthmark but never tested for AVM. The daughter had the AVM, brain AVM, superficial AVM, and then he came back with brain AVM.
So the RAS1 mutation is a completely different sort of syndrome that is inherited. The family members often have one or more smaller birthmarks scattered over the body. And for them, because that is inherited, so that is passed along parent to child, and that mutation is found in the blood. And those family members are at risk for AVMs in the brain and the spinal cord, and they have to be monitored closely for that.
And she also said her other daughter has a birthmark, so very heavy genetics with her and her two daughters. So Dolores says her daughter has Klippel-Trenaunay. She is 54 years old. When she was a child, she had issues with lymphedema. Now her feet are very swollen. I know that's not your area because you're Sturge-Weber, not KTS. But Dolores, you can reach out to me. We have extremity experts, and we can give you a referral to one. And Corinne, who is our chairman of the board, is on right now. She can post for you to reach out to us so we can give you a direct referral to someone. So Nicholas from Argentina says we have a 2.5-year-old son, Lorenzo, diagnosed with Sturge-Weber syndrome, but never got symptoms. We went to see you, the Kennedy Krieger Institute, and he started Bilateral and 1/2 aspirin a day. So we're doing it. The question is, our doctor here wants to stop the Trileptal when Lorenzo gets to age 3, but you told us we should do it at least until 4. What should we do?
So progression, patients with Sturge-Weber syndrome are most at risk for neurologic deterioration from seizures and strokes when they're very young. There is PET imaging data that suggests stabilization around the age between 3 and 4 years of age. And then there's clinical experience that suggests stabilization of clinical symptoms around that time. I suggest getting past that period before even considering removing the seizure medication and considering the low-dose aspirin. And that's because the child is on preventative treatment, which we have been using for several years. And the idea is to prevent the seizures, which can further reduce blood flow to the brain and put the child at risk for seizures. So we want to get the child past the vulnerable first several years of life before pulling away that medication. I understand wanting to reduce or remove the seizure medicine before the child becomes school age, but pulling it away too soon places the child at risk for regression. There are factors that would go into the timing of the decision, such as, is the child tolerating the trileptal or oxcarbazepine really well, or are there side effects? If there are side effects, then consideration of pulling it away sooner rather than later makes sense. If the child is tolerating it really well with no apparent side effects, then it makes more sense to wait till later, till the child is older.
So is this new proactive preventative procedure, like how long have you been doing this, where if on imaging they show it and they haven't had any seizures, you're putting them on the medication to prevent the seizures, correct?
Correct. Yes.
And then is there some plan now? Because I thought they were on the anti-seizure meds for life. So now they're coming off at age 4?
So we don't know exactly, okay? All right. So different parents do different things. And preventative medicine or preventive treatment we've been doing now for the last probably 6 to 8 or more years. Initially, it was low-dose aspirin only, and that was not effective in delaying or preventing the seizure onset, which is what we want to do. So then I switched over to low-dose aspirin plus oxcarbazepine, and if that causes side effects, then low-dose aspirin plus levetiracetam. And that's been more effective, generally speaking. So I have my first patients who now are arriving at 5 and 6 years of age, who are just now, who have been seizure free for all of that time, who are just now starting to come off of, some of them wanting to come off of the seizure medication. And so far so good, but we don't have a lot of time yet.
You don't have the data, so you'll see.
Right.
How it goes.
So we have one publication, a very early publication that came out in the last like 2 years ago, a year and a half, 2 years ago, on pre-symptomatic treatment, and that's from data from several years ago. It takes a while to get papers published, and we'll be looking at our data again in the near future and try to get some of the later follow-up out as well.
Yeah, I mean, this will be a long-term study, definitely. Especially once you hit puberty, you'll want to be looking at those changes.
Well, right. So we know from patients, not from the pre-symptomatic treatment, but just children treated for many years symptomatically, that some of them are able to come off of seizure medicine for a period of time, but puberty is a high-risk period of time where seizures can come back.
Yeah.
And so,
well, thank you for being on the front on that. So Nicholas has one more question for you. He said, what should we tell our doctor to include in the blood exam besides the oxcarbazepine rate and regular parameters? For example, we read that it's important to monitor the thyroid.
So I now check thyroid. So I have found over time that while it happens with increased frequency over the general population, it's still very uncommon in Sturge-Weber syndrome that they would have true hypothyroidism, either central or primary. So I check thyroids if I see symptoms, meaning excessive sleepiness, excessive weight gain, the child's not growing well, dry skin and hair issues. If I see any of those symptoms, then I will check for hypothyroidism. It's very important that not only a TSH be done, but a free T4 by equilibrium dialysis.
What's the correlation to thyroid? We don't know, or?
We don't know. So we've published actually a few papers associating Sturge-Weber syndrome with an increased prevalence, although it's still only a small subset of patients with Sturge-Weber syndrome, but increased over the general population because these issues are very rare in children, very, very rare, of central pituitary, growth hormone deficiency, hypothyroidism, and in a few patients, a very few patients, pituitarism. So a decrease in all of these hormones.
Very interesting.
So in patients who are not growing well, they need to have an IGF-1 checked if they're over the age of 2, and they need to be formally evaluated by an endocrinologist if any of these issues are present.
I'm assuming all of the patients with thyroid or adrenal involvement have meningeal involvement, brain involvement, correct?
They do, but the sort of what we don't understand is that when we look at their imaging, they have brain involvement with Sturge-Weber syndrome for the most part, although over time, I think I've seen one patient who had growth hormone deficiency and no brain involvement, but for the most part, they have brain involvement, but it doesn't look any different from other patients who don't have these hormonal issues. So exactly what results in these hormonal issues is not entirely clear.
Interesting. So we have a question from James Sakowski Bell. Her 9-year-old has been seeing Dr. Ballet for dermatology and Dr. Friedman for ophthalmology at Duke. He has port wine on most of the left side of his face and glaucoma. We've had multiple laser treatments on his port wine and 3 eye surgeries. He saw a neurologist at 6 weeks with negative results on the brain. He was hospitalized for possible seizures for a few days at age 2. Nothing since. We are only seeing those 2 specialists currently. Should we be seeing more regarding port wine and Sturge-Weber as he gets older? His lip is starting to swell, so he's got that involvement. And the left side of his face is definitely starting to grow a bit larger. He doesn't have any learning issues. That's very.
Okay. So I may have missed in all of that whether he had appropriate imaging, MRI of the brain with and without contrast, and all of the appropriate sequences to determine whether he has brain involvement or not.
He was hospitalized for seizures, so I'm assuming, yeah.
Well, so for possible seizures, it's so, I mean, if he actually had seizures, hopefully they did imaging. It needed to be done with contrast. And there are certain sequences that increase the sensitivity of the imaging to detect Sturge-Weber syndrome and to fully understand the extent of brain involvement. And if that was done and it showed Sturge-Weber syndrome brain involvement, or if he gets that done and it shows Sturge-Weber syndrome brain involvement, then yes, he should be followed by a neurologist, because even if he's not having a lot of issues now, during puberty, issues can develop, like migraine, like epilepsy again, like stroke-like episodes. The risk of stroke and stroke-like episodes is less in adolescents and adults, but it can still happen if they seize for a long time.
An interesting question, unrelated, but where was it? Somebody who's, I think it was Lori. So her daughter who has a CM-AVM, she wants to know, it says the port wine's not working. Well, port wine or pulse dye doesn't work on the CM-AVM. So Laurel, you should be communicating with Dr. Coletti, our expert who studies the correlation of laser with the CM-AVMs, because he's got some pretty interesting information on actually not doing any laser to those CM-AVMs, because it can kind of stimulate some stuff. So Corinne can post Dr. Coletti's email for you, and you should actually reach out to him. We have a lot of people watching. Greta Sadaka Loeb says, hi, Dr. Comi, my 18-month-old needs a shunt placed in his eye for glaucoma. We know we have to stop aspirin. What do you recommend for the amount of time stopping aspirin before and after surgery?
Okay, so you definitely have to follow the wishes and directions of your ophthalmologist and your glaucoma surgeon on this. The key piece is to remember after the surgery to ask, how soon can I restart the aspirin? When can I restart the aspirin? Okay, don't leave it on them to remember. That's really where the problem comes in. Okay, if they don't remember to tell you and you assume they're going to tell you, that may not happen, and then the child may be off the aspirin for longer than they should be.
Right, and most parents, when their babies are in surgery, are really just praying that everything turns out all right. So I tell them all, bring a notebook with your questions and do not leave without getting your questions answered. Bring the notebook before surgery and after surgery. So that's really important that you remind them to do that. So we have a lot more people. Holly wants to know, if a kid has Sturge-Weber syndrome but no brain involvement, does that mean he or she will never have brain involvement, or can the brain development occur over time?
If there's been appropriate imaging with and without contrast, with T1 spin echo, T2 post-contrast flare, SWI imaging done after a year of age, then that child has essentially been ruled out for Sturge-Weber syndrome brain involvement. If it was done earlier than that, though, they've not been ruled out. And it's not that it's like a tumor that grows and develops from that time until later. We think that it's the vascular malformation, like in the eye, like in the skin, and it changes. The blood flow changes. We know that from blood flow studies in infants over that year, so that later we can see it where we couldn't see it earlier. And so it really depends on the timing of the imaging.
And again, we talk about this all the time. You cannot say it enough times. I have so many parents whose babies at 4 months and then repeat at 8 months are having MRIs, and then they're said, okay, you're never going to have it.
Yeah.
You had 2, and they're not even 1 year old when they've had them done.
Right.
So what's your recommendation?
So for most of the patients, I see them. It's very important that they be seen by a neurologist and have someone that they're connected to. And I give them information about what seizures look like, doing a history, an exam, and an EEG, because that gives other information about brain function and whether there's any what we call ictal activity, an area of the brain that looks prone to seizure activity. And if the child is after 3 months of age, give them Diastat, which is a seizure medicine that they can use at home to stop a seizure until they get to the hospital. And I don't do really early imaging in most children because most of them are going to be normal. And if it's normal, we're going to have to sedate them again and do it again after a year of age to confirm the lack of brain involvement. There are a couple of exceptions. One is if I see them really, really early, I may be able to arrange for an MRI without sedation, in which case it's probably worth a look. If it's positive, if the MRI is abnormal, we can diagnose sometimes or strongly suspect brain involvement based on that very early imaging. And that gives us information. The other exception sometimes is a very extensive bilateral port wine birthmark. That child has a very high risk of brain involvement of 50% or more. And so it may be, discussing with the parent and how comfortable they feel about sedation, it may be worth going ahead with the early imaging to try to make the early diagnosis. If we don't do early imaging, and in most cases we don't, then I see them again in three months or so and repeat the process of exam, history, and EEG.
Thank you.
And then in all cases that are not diagnosed by a year, I recommend imaging after a year. Some families will say, well, if the child is fine, then why sedate them? Why bother? And the reason I recommend it is because there are certain things that I recommend families don't do if their child has Sturge-Weber syndrome. So, for example, there are certain activities like soccer or football or other sports that involve blows to the head that the child probably shouldn't pursue if they have Sturge-Weber syndrome. And they should be carrying Diastat with them if the child is at risk for seizures. And so there are modifications to lifestyle that should happen if the child has Sturge-Weber syndrome brain involvement, whereas if they can exclude that, then they don't have to do those things. They can just...
Well, and there's other exception to what you just talked about. You've done this a couple times where you've explained to the parents how to pick up these subtle seizures with the staring off to the side, the dominant hand. So if that's happening 2 or 3 months, then...
Yeah, absolutely. So that's the purpose of the history and the exam. So if the history, the exam, or the EEG is abnormal, then we would proceed with the MRI. Yeah.
But that's the issue. Parents are constantly saying to me, we don't know what's not normal in a baby. This is our first baby. And so just to take a minute, those three key things, if you could just review them again, especially in the young ones,
Sure.
the hand movement, the head, the eyes, if you could review that.
So handedness shouldn't begin in children earlier than a year of age. So if a child is definitely handed, meaning so if the birthmark is on the right side of the face, we're most worried about the right side of the brain. If it's on the other side, then we're most worried about the left side of the brain. The right side of the brain controls the left side of the body, and the left side of the brain controls the right side of the body. And so we know which side to sort of worry about. And so if one hand is mostly fisted, it's not opening as much as the other side, they're reaching and batting at things with only one hand. If they're reaching across the body to grab at things, instead of using this hand, they're reaching across the body to grab at it with the other hand. So they're definitely neglecting one hand. That's abnormal and needs to be investigated. If they are if there's a visual gaze preference, that suggests a visual field cut, and that would be on the basis of brain, not eye. And again, that can present with a head turn where they're bringing out the visual fields where they can see and they're looking at you like this, or they're just ignoring off to one side and they only pay attention to you when you're on the side where they can see. So those are sort of two main ways. And then the other issue is that seizures can be very subtle in Sturge-Weber syndrome. They're not big, usually they're not big shaking all over the body things in the infants. They're twitching that goes on. It's not just a couple twitches, babies are twitching, but it goes on for a minute, 2 minutes, 3 minutes, 5 minutes. In the hand, the foot, the eyes are bouncing and they just keep bouncing. You can't make it stop. Yeah.
And I recommend the parents to record that, and I've had them record.
Yeah, absolutely. So I get those, videos all the time from the patients that I'm taking care of. If they're worried that something they're seeing is a seizure, they send videos. Yeah.
So Olga, sorry, Olga, that took me a minute to get back to you. So she is scheduled for her 11.5-month-old to have an MRI. And she's like, should we wait till 1? I mean, it's almost 1. He has port wine stain on the forehead and eyelid, EEG, and ophthalmologist results are normal.
It should be okay, but I have to sort of tell people that we don't want to keep marching that back, because 11.5 months is okay. I don't want to say that 11 months is okay and 10.5 months is okay and 10 months is okay, because I don't know that. I know from my experience that over a year is okay. 11.5 months should be okay. That's pretty close, but we don't want to keep marching that back.
Right. 11.5 months becomes 11.
11, 10 months, 10.5 months, 10. Yeah, I don't know that.
So DC Albert wants to know if there's anything in the works for the treatment of port wine besides the laser. I am working with one of Dr. Comi's colleagues, Dr. Bernard Cohen at Johns Hopkins. He's been using an amazing self-created topical, which the patients are reporting little to no pain with his topical. So we're getting ready to do some kind of a study with him to improve the comfort level during the treatment. The Prima lasers out there. Other than that, I'm not sure if you're familiar with anything, but those are the two key things that we know about.
Yeah, results from using topical sirolimus in conjunction with laser have been mixed. I've had Dr. Cohen has also used that at times, and some families who were not getting any more response from laser, have reported to me that when they added that, they've gotten additional responses. But then I've had other patients who have reported to me that didn't work. So,
right. Dr. Geronimus and Dr. Nelson both did the topical studies with it and found it inconclusive.
Yeah.
The other thing is, because you have to look at when people delay, I just had a ton of parents say they couldn't get laser for 6 to 9 months, depending on the schedule because of COVID. And actually, when they got that first treatment, they had better clearance than they had had in the last 6 treatments.
Yeah,
So really, it's very interesting
that's interesting.
to let it go so that the laser then can snag the hemoglobin, because
Yeah,
it's more prominent. So all of this is the learning phase, right?
right.
So what is considered of age? Sorry if I missed that.
Of age. I'm not sure I understand the question.
I don't know what she's meaning, but I think maybe it's referring to, maybe she's talking about the imaging, for Sturge-Weber. Or if you had your preference, the first one would be done at 1, and then when would you do the second to rule it out? When would you have that done?
No, well, I rule it out after a year of age, and that's it.
Just 1 image?
That's right. That's correct.
So they don't need 2?
That's right. Unless, so I mean, for some cases, we do an earlier one, the cases we talked about. If there's symptoms, the EEG is abnormal, if the birthmark is extensive, if, yeah, things like that.
Yeah, they're showing symptoms of
Right.
seizures.
So for certain cases, I'll do a very early one. Or if I don't need to do sedation, I see them very, very early. But everybody else, I just do the visit, the history, the EEG, and then 3 months later, visit, history, EEG. If everything is okay, then just one imaging after a year of age, and they're done. Okay? Because the thing is, otherwise, the EEG is completely safe. All right. Well, right. These days with COVID, we're, sometimes a little bit more anxious, but essentially EEG itself is completely safe. There's no sedation, there's no medication, there's no x-rays or anything like that. And so we're using that along with history and exam to monitor the child. And then if everything seems, because most of the children don't have brain involvement, okay? So the risk is anywhere between 20% and 50%, depending on the size and extent of the birthmark. So the ones who have the risk that's close, that's 50% or over, makes sense to get early imaging. But if the risk is more like 20%, then, the chances are very high they don't have brain involvement, and, exposing them to sort of repeated sedation for, just that, when it's probably going to be negative, and you don't know, because early imaging doesn't exclude brain involvement. You're gonna have to do it again. It doesn't make sense to do that repeatedly.
Very good to know. I did not know this, because I thought the rule was get 1 done, then wait till 2 or 3, get the second, then you can rule it out.
Again, if you talk to different people, you might get sort of slightly different timing. This is how I've done it for a long time, and it's worked out well in terms of not having patients coming back and telling me that, it was missed or something like that. Or, I've followed many patients for many, many years, and that sort of process has not missed patients. So now, whether or not to get a very early image could change into the future as pre-symptomatic treatment, if that becomes a really proven approach. Okay. If we really get that right, we figure out what medication, what doses, starting when and for whom. If we really get that right, then the need to do early imaging on everybody as soon as possible becomes, that much more urgent, because you want to diagnose everybody as early as possible and try to get them on imaging, knowing that you're going to be imaging a lot of patients who don't have brain involvement, but right now, and a part of it too is what I do with 20 years of experience might be different from what someone who is seeing a patient and doesn't have all the experience that I have. They might decide to do an early image, if they aren't as comfortable with their, their history and their exam for Sturge-Weber syndrome. They might decide to go ahead with an early image to try to make the diagnosis, which, if the parents and the physician decide to do that, that's okay, as long as they do appropriate imaging.
Okay, well, that, there's a mom who's asking a question. Bree wrote us, and it was what I was just going to say to you. So thank you, Bree. She's saying Jackson, who's her son, is a Sturge-Weber syndrome patient. I'm not sure if he's one of yours. Jackson wrote us. He's super off today. He's acting fussy and tired, rubbing his eyes, blinking a lot, wondering if he has a migraine. He's never had one before to our knowledge. We've closed blinds and given Motrin, trying to eat lunch now and give fluids. Anything else we could do? Because I was going to ask you that we have moms of 1 and 2 year olds that haven't been diagnosed with Sturge-Weber, and they say to me the kids rub their eyes a lot or they hit their head, and they were wondering if the kids were autistic or if it was the Sturge-Weber. I mean,
whatever she can do to help him go to sleep is what he needs right now. Okay. So with the children who are very young, yes, it's difficult to make the diagnosis of migraine, but migraines can happen in Sturge-Weber syndrome from a young age. And the child who is very fussy, may be pale, or just a change in the color of their port wine birthmark, and may or may not vomit, and then goes to sleep and wakes up fine, and that happens repeatedly, that child may have migraines. And if sleep doesn't solve it, then I think you have to worry about, are they at risk for glaucoma? Are they having eye pain? That's another kind of pain that can make a child fussy, and you would want to talk to your eye doctor about sort of having, if they're rubbing their eyes, having that evaluated if that's a persistent symptom.
So Maria is asking, and thank you for that answer. Maria Hernandez is asking a question, and I always have a response to this. She's like, we just found out our 2-month-old has Sturge-Weber syndrome. And I always say to myself, how could you find that out if the imaging is inconclusive before age 1, unless they've had seizures, right? She said she's waiting for an MRI on Monday. Should we actually wait till he's 1? He had a CT scan on Wednesday as he had a bump in his skull side of his birthmark. This is how we schedule. I'd like to know how she found out.
So I don't understand. So, I mean, what does she mean by Sturge-Weber syndrome? Does she mean that he has the birthmark plus eye involvement? Some people call that Sturge-Weber syndrome. Right. What did they find on the CT scan? Was there calcification on the CT scan? That would suggest brain involvement. And did the child have seizures? Why did she say that?
Yeah, those were all my questions.
So, it's not that the MRI can't be positive early on. It can be. Okay, that's how we make early diagnosis.
Right. If there's evidence.
Yeah. So sometimes that's the tough part, is that sometimes early imaging is obtained and there is brain involvement. It's just that because the risk of brain involvement is 20-25%, most of the time the brain involvement is normal and they cannot be sure.
She just froze on me right in mid-sentence. Okay, Anne, you froze. All right, well, I'm going to keep talking because Anne may have to come back in, and you might have to go back out and come back in because you're frozen. In the meantime, Laura, if you want to answer that, Maria, where you said you found out your, there you are. Perfect. Okay. Yep, you're back. So, okay, so Lauren said they do prophylactically, they give a very low dose of Trileptal to her 4-year-old daughter. She has bilateral brain involvement, but has never had a seizure. That's a testimony to the prophylactic treatment or the preventative care. Our neurologist has suggested the dose is so low, he thinks it may be time to stop, to go ahead and stop. When do you think is the best time to let go of this? And she's got bilateral.
Yeah. So, I mean, with bilateral, that's tough because, both sides of the brain is at risk for an issue with seizures. I mean, what you have to understand is that the abnormalities in the brain has not gone away. To answer your question, better, to see your imaging would be helpful. I don't know if this is one of my patients or not, or someone I've seen in the past. I'm not sure, but
Lauren Lowe. I don't know if she's.
Yeah, no, I don't think so, but maybe. I don't think so though.
But you do telemed, especially.
Yeah. So that's something I wanted to let everyone know. I'm doing telemedicine now, actually, throughout the country and with other countries. So both national and international. So, and I do chart reviews as well. So if people have specific questions for their child, they can feel free to reach out to me. But I would be hesitant in a bilateral child, but perhaps when the child gets to be 5 or 6 years of age, perhaps. But what you have to understand is that abnormalities in the brain have not gone away. But I would want to look and see to what extent that deep draining vessels have developed. You'd want to get an EEG. You want to look at multiple pieces of information before deciding to do that.
Deborah Brubaker has a great question, and it's actually a study that I want to conduct, which is behavior around repeated laser procedures and so forth. And Dr. Nelson's going to address this, that he's been observing a little trauma in the children that have to go through the COVID and then the laser, that it's increased their anxiety. So she has a great question. She says, have you done any studies on the mental emotional effects of repeated procedures such as imaging, laser, eye surgeries? Our daughter is 4 and she's had all of this since birth. She's having problems with separation from parents pre-op and is extremely irritable, not wanting to be messed with for vitals. We're thinking of taking a break, which is what we recommend. The first 12 were with numbing cream. So we've been getting this a lot lately, like kids like having almost some like PTSD, and then we just tell them to take a break because you gotta, I don't know. So we want to do a study and actually like collect data and break it down into the under 6 months, 6 months to a year, 1 to 2, 2 to 3, and kind of see.
Yeah, so we've not done a formal study of that. We do have a psychiatrist working with us now. So if there was an interest in that, he might be interested. I could talk to him about that.
Yeah, I'd like to get in touch with him. Maybe he can come to our conference, which, by the way, everybody, our conference is on for December 12th in New York City. It will be held at Dr. Geronimus's office. We have 4 floors. They will all be COVID compliant, and each case will be handled as a clinic appointment in a routine office today. So there'll just be one patient, one parent, and 1 or 2 doctors at the most. So we'll be hoping that you'll be there, Dr. Comi, because worst case scenario, you could drive.
Yeah,
right.
Yes.
But we have quite a few patients that are holding on to this, and we're going to be sending out and publishing an announcement about it. But I'd like to really meet the new psychiatrist. So that'd be great to have somebody in our network to do some of these studies with. Most of these questions are people that are still talking. Yeah, her daughter, she said she's had 28 laser treatments, and that's another thing we have to start looking at, these vast numbers of treatments, and we're going to start collecting data on that. So Lily has a question for you. Lily Sadaka has an 18-month-old with Sturge-Weber. We've had our normal bouts of different viral illnesses and fevers. I have asked both, it's a long one, our hematologist and neurologist about Motrin for fever when Tylenol isn't working, also about the need to stop aspirin during fevers. I received contradictory advice and would love to know what you tell your patients, whether it's okay or not to give Motrin to our Sturge-Weber Syndrome kids, and if aspirin needs to be stopped during fever.
Okay, so I have not seen issues with Motrin used for migraine or for fever causing issues. So I go ahead and let families use it without a problem. Even combined with aspirin, I've not seen a problem. And in terms of aspirin, I do not recommend stopping it or cutting it during a febrile illness or virus, because that's exactly when the child needs it. Okay, those concerns come from when aspirin was used at much higher doses um, for uh, for pain and for fever control. The aspirin dose that we're using for Sturge-Weber syndrome is low dose aspirin, which is much lower than the doses that was used decades ago when it was associated with Bry syndrome. Okay, low dose.
What's low dose? 85?
No, well, it's dependent on weight. So it's 3 to 5 milligrams per kilogram per day, up to a maximum dose of 325. Okay. And you know, as tolerated, obviously. So Bry syndrome has never been associated with that, and it's used in millions of children worldwide for stroke prevention. And side effects can include increased bruising, nosebleed, gum bleed. Anything else is extremely rare. So yeah.
So Bree did say you are her son's doctor. So
Okay.
you've already told her you can do a telemed with her concerns. So,
Okay.
And Maria Hernandez said, yes, there were calcifications. So you asked if there was anything, how they knew. I wanted to know, how did they know the baby at 2 months old had a Sturge-Weber? And she said, yes, they found calcifications.
Okay. All right. So that makes sense. Okay. So, you know, that can show up on head CT. And so I would go ahead with the MRI. Okay. Because that will delineate, as long as, again, they use appropriate sequences, and they must use contrast. And you know, you can reach out to me if you have questions about that, but it will tell you the extent of the brain involvement. And that's important early on with regards to, if you're going to start pre-symptomatic treatment, how aggressive to be with that pre-symptomatic treatment. So if the if the brain involvement is very extensive, then, you know, I highly recommend both aspirin and oxcarbazepine at a moderate to high dose as soon as possible, because, you know, much of the brain is at risk. If the on MRI, only a very small area of involvement on one side, just the occipital lobe or occipital-parietal, just small area, then I don't always start pre-symptomatic treatment on those kids, because chances are they're going to have later onset of seizures anyway. And when they have later onset of seizures, they're going to be easy to control, and they're not at risk for all kinds of neurologic deterioration. So, I mean, it's a discussion.
Bravo to this mother at 2 months old getting this diagnosed, because you and I both know, I've been doing this 25 years, you too, that the mom's awareness about this earlier now is really helping a lot of these babies, because it used to take so many years for them to get an accurate diagnosis. But, you know, bravo to her at 2 months old to get this identified and under control so that she can get it taken care of properly. Robbie wants to know if there's anything new about BNSN, which is blue rubber blood nevus syndrome. If it's for a pediatric case, Robbie, we will put you in touch with Dr. Bernard Cohn from Johns Hopkins. He's our BNS expert in pediatrics. If it is an adult, we will put you in touch with Dr. Roy Geronimus in New York City. So I don't particularly know if there's anything new. I don't know.
I don't either. Yeah, no.
Yes. Okay. So, Lauren's saying she did a chart review when she was a baby, but it's been years. Okay. Well, like Dr. Comi said, she's available for telemed. Ashley Hawken Derrick said she's had a couple doctors say that my 6-year-old doesn't have Sturge-Weber, but his pediatrician says he does. If he has a port wine stain and glaucoma in both eyes, but no seizure, what is the right answer? He's got bilateral glaucoma. So,
I would actually want to sort of know more about the child, because it's possible to have birthmark, glaucoma, and other features and actually have something else. So the capillary malformation macrocephaly syndrome can have port wine birth, have capillary malformation, glaucoma, macrocephaly, large head, frontal bossing, and they can be at risk for things like kidney problems. And so that actually is important to sort out. But let's just say that's very typical port wine birthmark and glaucoma, and no other features suggesting anything else. Yes, we can call that Sturge-Weber syndrome, but I tend to say my child has Sturge-Weber syndrome involvement with skin and eye involvement only. Okay, to clarify that. It's, there is the sort of type 1, type 2, type 3, but everyone sort of gets that confused. I have to think about it myself to get it right. So I tend to just say my child either has only a port wine birthmark, but is at risk for brain and eye involvement, or is at risk for eye involvement if they're older and have had imaging to exclude brain involvement, or my child has Sturge-Weber syndrome brain involvement only if they have no birthmark and they're really not at high risk for eye involvement, or they have Sturge-Weber syndrome brain, skin and eye involvement, or skin and eye involvement only. Basically sort of just say what they have. It's longer, but it's really clear.
yeah, so Laura Rossetti is asked, you just answered her question because she wanted to know, is there a consensus about the type 2, which is only the glaucoma and tissue? And you basically answered that with no brain. Maybe she wants to know if they're diagnosed with it. And this is a really important question. And by the way, we only have 8 minutes left, but this is important. If they're diagnosed with type 2, which is the glaucoma and the stain, and they've never had imaging done, can they develop the brain involvement?
They can, because 10% have onset of seizures or neurologic symptoms after 2 years of age. And it can be in childhood, puberty, adulthood. The oldest patient I ever had was in her 60s, had first onset of seizures. And so if they've never had appropriate imaging after a year of age, it's possible. It's not very likely, but it's possible to have brain involvement.
If they've had the imaging and it's been ruled out, then they're clear to go.
That's right. It's because it's not a cancer, it's not a tumor, it's not going to like grow out of nowhere. It either was there or it's not. And if you had the appropriate imaging after a year of age, you've ruled it out, essentially.
Oh, this is interesting. So Deborah Brubacher is saying that her daughter's going to have Botox on her weak hand in October. Is that something new?
So that on occasion, there have been patients that have pursued that and found that helpful when there's been really bad spasticity or dystonia issues in the hand or the foot. It's not super common that's used, but we have had patients here and there that have used that and found that helpful. And generally, I get one of my medical rehab colleagues, we have one in our center, Dr. Suskauer, involved in deciding whether that's going to help a patient or not.
I'd like to read more about that. It's a very interesting concept. So with bilateral, Carney Broadbent wants to know, with bilateral involvement and brain shrinkage already noticeable by 12 months, how much will the brain shrink? Does it continue, or does it plateau and stop shrinking at some stage? Is this what calcification is?
Well, I would have to know exactly what the imaging looked like to know if further shrinkage was likely. It can further shrink after a year of age. If the atrophy, which is shrinkage of the brain, is only mild or moderate, it can be severe if things really continue. Calcification and atrophy kind of go hand in hand. It's not exactly the same thing. Atrophy is the brain not growing as well as it should, or actually shrinking. And when it's mild, you can have just a bit of that and no calcification or very little calcification. When the atrophy gets to be moderate or severe, you almost always have calcification along with the atrophy. Calcification is release of calcium and other factors out of the vascular cells and cells surrounding the abnormal blood vessels into the area around those cells, and as like crystals. And both atrophy and calcification are caused by abnormal blood flow and injury to that tissue.
Okay.
And it doesn't happen in everybody. It's very variable.
Yeah. Well, we always say there are no two port wine stains.
That's right.
Like, you know, because we're getting to the end, and I have an important question for you to talk about. But you've already said this, but for the sake of Christy Brookings Ebel, her 6-year-old has had an MRI when she was 2, and everything was fine. She's saying, should we do another one? You've already said no if everything's fine.
As long as was done with contrast, it has to be done with contrast and appropriate sequences, it should be okay.
This is a very good question. Thank you, Carney. She wants to know, is there any risk with putting a child under general anesthesia, whether it's for laser or something else when they have Sturge-Weber?
So that's, we don't know for sure. Generally, there's not an apparent clear issue with sedating a child. We would know that by now if there was a clear problem, if patients were regularly having strokes or bad seizures after sedation. That does not happen. The whole concern for babies in general of having sedation and whether that has a negative impact on cognitive abilities or long-term effects is controversial. And initial data came from baby rats and having negative effect on their brains. And we don't know if that translates into babies. Right now, I would say that the field, most people where it stands is that we avoid unnecessary, sedation in babies under a year of age, but where it's necessary, where it's helpful, where it needs to be used, we, encourage families not to be excessively worried about it because, literally millions of babies and young children have had sedation and general anesthesia without clear, obvious negative impact of that. So I know that's not a great answer, but that's, I do think that that patients with port wine birthmarks and no brain involvement versus those that have brain involvement, is an important area to study. Okay, and those who get general anesthesia and those that don't get general anesthesia. And, I would be really interested in sort of helping or being involved in such a study, because that would not only inform our patients, but that would provide really important information for parents of babies like all over the world.
Yeah, I think
that issue.
Yeah, we could work with you on that, with Cohen doing the laser, with Geronimus, with Nelson, and maybe one of our international doctors. That would be a great study. So let's talk about that. Okay. I really want to get in a couple more of these parents' quick questions before we go. Even if we have to take an extra minute, we'll stay. For the bilaterals, should they get repeat MRIs simply because it's bilateral if there's no seizures?
So the only time I do, so there is a time where I do repeat, okay? And let's say that they did get early imaging, like this child, a 2-month-old, is going to get imaging now at 2 months of age, and it diagnoses brain involvement at 2 months of age. Okay, I will still oftentimes, maybe not all the time, but oftentimes recommend repeat imaging after a year of age in order to know for sure what's the full extent of brain involvement, because it is possible to have early imaging done that makes the diagnosis of, say, extensive unilateral brain involvement, and we decide to go on some kind of pre-symptomatic treatment. But we want to know after a year of age, does the child have unilateral or bilateral brain involvement? Because that can impact questions like, are they a surgery candidate? Should we go to even higher doses on our pre-symptomatic treatment because the child is in fact extensively bilaterally affected rather than unilaterally affected? So there are times where we would, it is possible to think that a child has one side of the brain involved because they had early imaging and they actually have bilateral brain involvement.
Yeah, this child was for bilateral brain involvement, but no seizures. And probably because put on the medication early, who knows? But you would probably still recommend follow-up imaging, correct?
So I don't do, any kind of sort of every year follow-up imaging, or I do because you have to sedate, and because most of the time the imaging doesn't, after a year of age, doesn't have, at least with the sequences that we have, if the child is doing well, progressing, developing, making good milestones, you're not going to see a lot of changes on the imaging. Okay. So, unless it's going to change what we do, I don't do imaging on some sort of regular whatever. If there's a plateau in development or a regression in the development or seizures on the other side of the body, then something that worries me, then I get imaging done. Often we'll get EEGs done, like an overnight EEG looking for, missed seizure activity, things like that.
Okay, I have one more question, and then we're going to close with any comments you have on Sturge-Weber and COVID patients.
Okay.
Yep. As well. So this last question is from Anna Mascuco, and she's saying her 19-month-old daughter is treated with valproic acid. Her thyroid levels are elevated. Her skin is dry. She's gained a lot of weight. Could this be related? Her daughter has Sturge-Weber.
So I'm not sure I understand about the thyroid being elevated and all of those. But if she wants to reach out to me, I can try to help sort that out. Those symptoms sound like low thyroid, but yes, it could be related.
So Corinne will post Dr. Comi's email, and you can schedule a telemed with her. She'll also be at our conference in New York City, Lord willing. We will be taking it one day at a time and listening to Andrew Cuomo's, our governor's updates. But let's close this by thanking you, Dr. Comi, and lots of questions from our Port Wine Sturge-Weber community on COVID, whether it could impact seizures, or because some people are talking about it being endothelial, vascular related. What is your experience? What are your comments? What do you have to say about COVID and Sturge-Weber?
Well, so first of all, my data or direct experience is limited so far because most of my families have been strictly quarantining, and so nobody's been sick. I have very few families who have actually had COVID or been suspected of having COVID. I would be very interested in hearing from you if you've had COVID, meaning your child has had COVID, and hearing about your experience so that I can add that to, what I share with families, because every time I see a family, they want to know, how should I advise my child, et cetera. What I can share with you so far is very limited. So there have been, 4 or 5 patients who have had COVID or been suspected of having COVID. the couple that ran into trouble, one was a baby and had lots of seizures and was hospitalized. The other was an older patient, but very medically frail, who was very much suspected of having COVID, but was repeatedly tested and was negative, whatever we want to make of that. The other patients who have had it or been suspected of it were older and essentially healthy, fairly neurologically intact, and all did fine. So, a week or two of fever, cough, symptoms, but, came through it just fine. So that's my very limited experience so far, and I'd be happy to hear from people.
Yeah, and we've got some data in our study too about how many people had COVID of our 840. It was so low, like 3 people. But one last question. Lots of parents with children with Sturge-Weber wanting to know if they should send them to school or not. And you just said you think the reporting of the COVID's been low because they've been really great about quarantine. Mm-hmm. So what do you think about them?
I've had sort of individualized discussions with families about this. And I think every case is different because it's not just that child, but it's other family members. Are they living with grandparents? And also, is that child a sort of very sort of medically frail? Are their seizures not in that great a control? Are they wheelchair bound? Or are they a basically very healthy child? And then on the flip side of that is how well does virtual schooling work for them? So for some children, it just does not work at all. Okay, they can't pay attention to it. They're not learning. It's just a terrible experience. For others, it really works pretty well. They're able to learn. They're making progress. It actually is a good fit for them. And so there's many factors that goes into the decision.
Yeah.
So it hasn't been sort of a one size fits all recommendation. But the safest thing, of course, is to stay home. But I think you have to sort of look at the full picture to decide what's best for you and for your family.
Well, it's been wonderful, Dr. Comi. Sorry we went over, but it was very important and a very good session. And thanks to my social media marketing, Emily Ling, for getting me through this Zoom session with you, our first one, very successful. And Dr. Comi, you'll be excited to hear several people have been posting to me that they did have COVID. So we posted an email. One of them was pregnant, and she's got some interesting things.
Okay. Please contact me, or Linda, please share that information if it's okay with them, but please contact me because everyone wants to know. And so, I'm seeing, several patients a week, and every last one of them wants to know. And so whatever information we can share is helpful.
Yep, and Dr. Comi's email was posted by Corinne Barnaga, our chair. Thank you, Corinne, for being on today. And so you can write to her, those of you who you've had COVID, someone in the house had COVID, your baby's had COVID, please let her know. This is important data for us to share with other families as well, especially because we don't know what's going to happen in the future.
Right.
As a matter of fact, we don't know anything anymore.
No, thank you so much.
But thank you, Dr. Comi, so much for
Thank you, Linda.
Important and informative session. Thank you all for joining us. This you will be able to go back and view as many times as you want. We will have it on our YouTube channel. It'll be on our Facebook page, so you can go back and re-listen and hear the very important things that Dr. Comi has had to say. Thank you all. Thank you again, Dr. Comi. And we'll be back on December 9th with Dr. Stuart Nelson to talk about laser treatments during COVID. September 9th, sorry, what did I say? September 9th to talk about port wine stain and laser treatment. So thank you all. Stay safe.
Thank you. Take care. Bye now.